You are now listening to Nailed It, the Orthopaedic Surgery Podcast.
Hello, everybody, and welcome yet to another episode of the Nailed It Ortho Podcast. I am one of your hosts, Dr. Cole. Myself and Dr. Fitts started this podcast to go over high-yield orthopedic surgery topics. And today we have another great one. Actually, finally going to do another joints talk. It's been a while since we had a joints episode, so I'm looking forward to it. And we have Dr. Antonia Chen to come and speak with us a little bit about total knee arthroplasty, extensor reconstruction, or extensor mechanism reconstruction, and a little bit more about Dr. Chen. She did her med school at Ruptures up in the North Coast, did her residency at the University of Pittsburgh, which we were just talking a little bit about off air, and she did her fellowship at the Rothman Institute in total joint arthroplasty. So, Dr. Chen, welcome to the Nailed It Ortho Podcast. Thank you for coming on and being a guest. So, welcome.
Thanks so much for having me. I'm excited.
Yeah, I think this will be a good episode. This is a topic that I definitely see questions asked about, but you also see it in real life too. So I am super interested to talk more about total knees and extensor mechanisms and dive a little bit deeper into it.
Sounds good. It's a fun and terrible era to be in. So let me tell you, there's goods and bad sides to it. There's definitely questions, but you never want to get these in real life. But when you do, you want to know what to do with them.
Yeah, exactly. I think that's kind of the goal of the episode. And first off, what we kind of like to start to do is just ask a couple questions, get to know you, and then we kind of transition into the topic. So first question that I have for you is if you could kind of go back and look and give yourself some advice from when you first started residency. Is there any advice that you would give yourself now, having gone through everything and being an attending, doing all this research and, you know, making a name for yourself? Is there any advice that you would give yourself as a resident, or I guess any just general advice?
General advice I would say is keep your mind open. You may not believe me when I say this, but I actually wasn't really interested in research when I started residency. I did research as a medical student because we had to. That was part of our way of getting into orthopedics. So I think I had one paper when I applied for residency. Now, if you have one paper, you're done, right? You can't even apply. So it's crazy how things have changed. And it just became something that I got interested in when I was a first year resident. As an intern, there was a research meeting. I decided to do some research. So keep an open mind. You know, I really flirted with the idea of going into spine. Didn't end up going into spine, did joints because I actually like good patient outcomes. That said, keep your mind open and enjoy different things. So for all you spine listeners out there, I apologize in advance. The surgeries are awesome, but man, those clinics are hard.
Yeah, it can be rough in some of those spine clinics. Okay, a second question we have for you is, do you have any books that you have gifted to others frequently? It can be books on anything, doesn't necessarily have to be about orthopedics. If it is, cool. But do you have any books in general that you gift to others?
That's an interesting question. I've actually never been asked that before. I think something that that's really important to me, but that's totally outside of orthopedics, is my faith. And so The Case for Christ is a book
Okay.
I've gifted to others. So something very different from orthopedics.
Awesome. Good. That's a good one. You know, we always love to hear people's, you know, interest and thoughts outside of orthopedics, because we do have lives outside of orthopedics.
You do?
And that and that is a perfect transition into the third question is, do you have any activities or things that you enjoy doing outside of the field of orthopedic surgery?
I do. I like to ride my road bike, and I also like to Peloton, and I like to play with my little Yorkie Lily.
That is awesome. After you said road bike, I was just about to follow up with a Peloton question, but you already addressed it. So I am glad you have joined the Peloton crew. I have not joined it yet, but one of these days I will. But I hear so many great things about it, and
It's only a matter of time.
Workout. Yeah, I know. They're a little expensive. One of these days, I may
get
admit,
one. It was a good attending gift to myself when I had it. Yes.
Awesome. Well, Dr. Chen, let us transition a little to our talk of the day. And what I think would be good is to kind of cover a couple different ways of how, you know, we're talking about extensor mechanism failure. And what we can do is talk about a couple different ways of how or where that failure can occur, and then we can transition into extensor mechanism reconstruction. Um, so say, for example, Dr. Chen, you have a 75-year-old male who came to your office. He had his total joint replacement done at an outside facility somewhere many years ago. Does not remember where, and he actually went to the ED a couple of days ago after falling directly onto his knee. They diagnosed him with a patella fracture. They did not call you at the time, and he showed up in your clinic. And so, kind of from there, um, if we could just, can you kind of just go over kind of what these extensor mechanism failures are, how often you see them, and what are some of the first things that come to your mind when you hear this story in clinic?
It's always interesting, actually. So, one of the things you're highlighting here is the fact that it is very rare. And I will tell you, one of the interesting things being in practice is that I don't always see them. So if someone comes in with a fracture, patella fracture, they end up with a traumatologist normally. So while they might have a joint in there, they may not always end up with me. And this is true for hips too when it comes to periprosthetic fractures, right? So,
Right.
there's a bone must fix it kind of attitude happens and they end up in trauma clinic. So the incidence, while this low, might be even lower in an arthroplasty surgeon. On the flip side, if there's a joint in there and you're in an area that there's not a lot of traumatologists, it might show up to you because there is a joint and there's metal in another place. So they don't often come into my clinic. I definitely have a few people who do exactly what you say. They fall, they either go to the emergency room or they don't go to emergency room. They hobble around and show up at my office or show up at one of my colleagues' office being like, hey, I had a joint replacement done. There must be something wrong with the joint, the knee, go ahead and fix it. So
Right.
then I would go ahead. Yep.
No, go ahead.
My favorite one was a guy who was gambling. It was 3 a.m. He fell and tripped into the elevator. His wife got him into the hotel room and they showed up in my office. That was pretty fun.
Oh, wow. Straight from the hotel room to the office?
They were able to get into an appointment or that day actually, because we
Oh,
have
wow.
a 24-hour turnaround. So they showed up and I go, what happened? He was like, it was worth the gambling though. And I said, well, there you go.
It was worth it.
There you go.
So say that this patient shows up and they have a patella, this patient that just happened to have a patella fracture. Are there any things that would make a patient more at risk for having a periprosthetic patella fracture? I know we just said that this happens not too often, or it's a rarer injury, but what are some, like, why would what are some things that we should just be on the lookout for, and some risk factors for having this patella fracture?
One of the things that you have here is a question mark is one of those things that's being probably more and more tested for you guys. So back in the day, I think everyone got their patellas resurfaced. And as you probably can guess, when you resurface the patella, you're not supposed to make it too thin, but sometimes we see those 10, 11, 12 millimeter patellas that are cut way too thin, and they can actually, they can just fracture without much trauma, in all honesty. So patellar resurfacing, I think, is one of those areas that's becoming more tested because less and less people are resurfacing the patella. That really started over, I'd say, overseas in Europe, and then kind of made its trend over here. And there's some centers that rarely resurface, and there's some centers that only resurface. So the problem is that these patellas become thin is one. Two, they can be devascularized from surgery itself. And one of the big areas too is one thing you highlight here is implant malrotation. So one of these things as a arthroplasty surgeon, we be careful because yes, we got an x-ray we see here and it's very obvious there's a patella fracture. There's clearly a gap there. But more importantly is if you're going to go into the joint, do you just acutely repair the patella, or do you find out there's something else going on? And that's when it comes to implant malrotation. Sometimes I will get a CT scan for patients. I really actually try to get old x-rays first. I go get old x-rays and I really want to get a merchant view. I want to see if that patella was tracking correctly in the first place. It may not have been. And if that's the case, I'm going to go and revise. I want to do everything simultaneously as opposed to taking the patient back 2 times to correct their deformity or their problem.
Are those the patients that tell you, are things, something that would kind of clue you in to getting a CT scan? Is it if they come in and say that they are having knee pain before that patellar fracture, would that be something that would clue you into towards malrotation, or is this routine with almost every periprosthetic patellar fracture, you'll get a CT scan?
It's a good question. The nice thing about a CT scan is I can see what bone stock I have for the patella, right? So you guys think of when you're in trauma, And a lot of times these people will get a CT scan because you want to see what you're working with for fixation. I don't do that for every single person, I have to admit. I'll ask patients, do you have a history of your kneecap moving to the side? Do you feel like when you're going up and down stairs, it feels like your kneecap is unstable? So normally there's something in their history that might clue me into getting that, because I don't think the patella tracking may not be ideal.
Okay. And is there any specific width of the patella that you don't want it small? I know you mentioned 10, 11 millimeter cuts a little bit earlier. Is there any width that you don't want the patella to be smaller than that increases your chance for fracture?
So that's the one I try to go for. I try not to go under 12 millimeters of thickness. So in the side view here is the best way to see the thickness. They actually have done studies where our fingers are actually very good metrics. So we can use calipers that they offer. Each system is a different type of caliper, and they all are great in all honesty. But that said, you can use your fingers to feel the thickness there, measure it, and go from there to try to get a flat surface. The hard part about looking at a lateral like this on an x-ray is that it's only 2D. Because of that, you can't tell if it was really thick in one part or appropriate in one part and then too thin in another part. So 12 is what I try not to go below. Normally what I do is I'll measure the patella and then ask what the thickness of, or know the thickness of the component that I'm going to place in there, either 9 or 10 millimeters. Normally, for a really big one, it can be up to 11 millimeters, and then resect that amount because you don't want to overstuff the patella either.
Right. Yeah, because that could also lead to patellar maltracking and problems in the future. And so, what are there? Because when I was reading, just preparing for this topic, there were things such as, well, let me backtrack. Anytime I've done the most total knees that I've done, I've seen on the patellar button there are 3 pegs that normally fit into the patella. So you ream and make those 3 holes. In reading, they were saying implant designs with a central peg was one of the things that increases your risk for having a fracture. Are there any other, I guess, implant specific or technique cement wise that will increase your chance for a patella fracture?
In these cases, when it comes to patella fracture, I think more what happens is that the patella button comes off. And then if the button comes off or doesn't have good fixation, then you don't have that same thickness that you would have that's reconstituted as a whole thing. So the central peg ones are older, and luckily they learn from that and put 3 pegs into it. But if the fixation is not good, then it comes off and it's rubbing around in the joint, and then it can actually cause, trauma to the patella itself. Cementless, as you mentioned, there is a big one too, because it may not grow in. If it doesn't grow in, then it's also loose. When it comes to cementing techniques, and this is true throughout the knee as well, you don't want it too doughy, you don't want it too runny. And this is kind of like the Goldilocks of cement. So whatever I do is after mixing cement, I put it on the components first because it's in that phase. And then once it's the working phase, you want to put it on there. And 2 things that I say when it comes to cement the patella: first, you want to make sure that it's not too late. Right. So sometimes you get that cement psychosis where you're like, oh my gosh, I get cement on. And by then you're really pushing it in. And it's really hard to get the cement into the patella. At that point in time, it might be worthwhile just to open up a new pack of cement, as painful as it is, to cement the patella with a fresh pack. And then 2, on the flip side, you don't want to make it too runny because you want to have interdigitation and push it in. And then number 3 is once you put the patella clamp on, don't take it off till the cement is hard. As orthopedic surgeons, we are not very patient. So the first thing we want to do is yank that thing off and start closing the wound, but you got to make sure it hardens.
Yeah. And when these patients come into your clinic, is there anything that you particularly, on the lookout for on a physical exam when you see them and you're examining these patients?
I want to see if they can straight leg rise. Normally for these patients, what you can see is if they have this, let's say, patella fracture, and they've had this for years. I had a patient who walked in there. Patella was, a good 6 centimeters split down the middle, apart from each other, and they could do a perfect straight leg rise with no extensor lag. That's pretty impressive. That also means there's a lot of fibrous scar tissue in between that did the trick. So it's one of those things where, you want to check if the patella component's loose, and if there's a lag, then there's something you want to repair more acutely than not.
Right. And so I guess quick and dirty, how is there any, what are the surgical indications or patients that you would operate on that have these patella fractures around, a total joint arthroplasty?
They have a patella, I must fix it. No, I'm just kidding. The idea is exactly that. You want to say they can't function, right? You can't walk
Right.
around with a continued lag, and 20 degrees or more is really the metric that people use. So at those points in times, and a patient can't live in an immobilizer. Now, if a patient's really sick, really old, and taking them to the operating room is going to kill them essentially, then maybe it's not a good idea to do it if they have like a 20 degree extensor lag only. But if they really can't straighten the leg, they walk with the crazy thrust, it's not good for them long term. So anytime there's a lag, I'll take them back. And if the component is loose, they can't live with that. Their knee kind of floating around. So that's another one too.
Right. And then otherwise, besides, just having a total, an implant in there, is it just pretty much this AO basic principles you use? You use Cancel screw, you use screws, or you use tension band, or is there anything in particular that you use for these?
So the hard part about putting screws in is normally that patella is pretty thin. So if you put screws in, you're probably just going to put into a bag of mush, or it's not going to really hold well. So without the patella component, either way, I'm a tension band person. That's just what I learned in residency, and I feel more comfortable with it. So that's what I'm most likely to do, and it really can hold it together then. So that's my go-to.
Okay. Okay. That's pretty cool. Anything else that you think, we should know just about patella fractures, periprosthetic patella fractures?
Yeah, the reason to get a CT scan, honestly, is to look at your bone stock to see what you can get purchased into and bring it around. Sometimes people like to do the, drill holes and the Houston suture passers and, do all those sort of things to make sure you have enough of it. It's tough to say. Sometimes as arthroplasty surgeons, we don't like to admit we need help. So if you do need help, and this is true for residents as well too, go ahead and call your trauma colleague who fixes a patella fracture every week, and they can help you out too. So it's okay to have help.
Right. Yeah, it's okay to, not be too prideful and say you need help with it. Yeah, at the end of the day, it's for the patient. So you're trying to do what's best for the patient. If the trauma person's coming, helping out is best for the patient, then, don't be too prideful to ask for a little bit of assistance. Now, I say, because another, when we're looking at our whole, extensor mechanism, we have our quadriceps tendon, we have our patella, and then our patella tendon. So, we just talked about our patella itself, but can you kind of touch base on, kind of quad tendon ruptures and, how you evaluate these and, if there are any risk factors or what you look for in these patients?
So it's always fun because I remember as a med student, they're like, what's this palpable defect? And you go feel it like, whoa, it really is a palpable defect. You can stick your fingers right
Truly
into it,
is.
right? Right above where the patella should be. And there's a big space, then they can't extend their leg. So that's pretty interesting to see. This is more of a sports injury. All right. So this is one of those things where we saw probably more in sports or repaired more in sports. So use your Krakow technique and, kind of bring that all in together. But it's so key in these cases that you need to have a good extensor mechanism. And if your quad tendon is ruptured, you want to try to repair that acutely rather than waiting a long time with this. So things that you can do is you can get an MRI, you can get an ultrasound, but most of the times you can get it through an X-ray here. So you see patella baja. So whenever you see the kneecap going down, we can use something called Insula-Savati ratio. You measure the length of the patella to the length of the patella tendon. And if it's, less than 0.8, then it's Baja. And so in those cases, you want to make sure that you reconstruct that, because if they have an extensor lag, same as the patella fracture, you can't function with that.
Yeah, I like it. We're getting a little sportsy here. I dig it.
Danger
and,
zone, danger zone.
and so, what is your typical treatment for quad tendon ruptures? I know you mentioned a little bit earlier that we're looking at our extensor lag. We mentioned more than 20 degrees being a surgical indication when we talked about patella fractures. But what's your treatment algorithm for these patients that come in with a periprosthetic quadriceps tendon rupture?
It's really hard. So we talk about sports, and those people normally have nice athletic legs or thinner legs, and they're able to, put a good brace on it. The hard part about some of my patients who are older and may not be the most mobile is getting a brace on them can be really hard. And compliance with the brace, locked in extension, and ambulating can be difficult. Now, they have no problem walking the walker. They prefer to do that, but crutches, forget about it. So if it is less than 20 degrees, I agree that the idea is you can put them in a brace. Sometimes actually people do well with a cylinder cast, as painful as
Yeah.
it is. It keeps them as long as you trust them to, be good with their skin and, take good hygiene, and they're not, 5-year-olds in cast, thankfully, you can actually immobilize them for 6 weeks and then start moving it, and take it off, bivalve it, and, things like that. So those are options that you can do for these patients. But I have to tell you, this group of patients, they don't tolerate this well, in all honesty. Their quad function is normally not that strong just to begin with. So if you put them in this brace, they don't do necessarily well. So I have a lower threshold for repairing the quad tendon in these total knee patients than in other patients, I would say.
Yeah. And so do you have a preferred repair technique?
So I hope to catch these early. A lot of these people do show up in the Boston area. People are very acutely attuned to their health. So the second that they have a problem, they are in your office. So I like acute repairs. If you can do end-to-end repairs, that's the best way to go. I'm a crack house stitcher, all the way up, all the way down, pull them through. And then if you need to, you can drill through. I like that. I like fixing, getting bone fixation as much as possible. So drill holes, I prefer to suture anchors personally. I hope not to supplement. I don't like supplementation just because allografts aren't necessarily the best. But if you need to get scar, you need to get scar. So that can be useful.
Yeah. And I know you just mentioned that, in Boston, everybody, something's going on with the knee, they're in to see the doc. But so say, for example, you have a patient that just moved to Boston who has had this chronic leg problem. And you go and you see them and just like you said, Patella, Baja, they say, hey doc, I can't really kick my foot all the way up. And you look at them and they have an extensor lag. Well, actually, let's take a quick step back. Sometimes we have medical students that actually listen to this. Can you explain what an extensor lag is and what you would see on physical exam? I know this, to me, it's pretty clear, but then we may have some that may not exactly know what that is.
No, that's a great point, because it's something I didn't know well as a med student, in all honesty, because I thought anytime that the leg, if you try to extend the leg and you can't fully extend it, it had to be a flexion contracture. So there's two differences of a flexion contracture and extensor lag. So ideally, a patient's able to fully extend their leg. And if they can fully extend their leg, they have no contracture and they have no lag. What does that mean? If you have a patient who has a flexion contracture, they can't go past a certain point, with you holding it or them doing it either. So if you can imagine a straight leg being 0 and it's bent just a little bit, let's say 10 degrees down from the straight across and down a little bit. If you're trying to push up against it and you're holding it and trying to push down on it and you can't get the leg to straighten, the patient can't get the leg to straighten, that's a contracture. Versus a lag is if it's 10 degrees and it's bent down and the patient can't lift it up fully because they don't have the quadriceps tendon or the patella tendon or the patella itself, which makes up the extensor mechanism. If they don't have that ability, they can't lift it, but you can take the leg and straighten it out. So if you can straighten it out and correct it to 0 degrees, then they have a lag, because they have a lag of ability to pull it straight up on their own, but you can do it. So it's not a physical block.
That was an excellent description of what an extensor lag is. So just like we just said, so say for example, we have this person that just moved into your office. They've had this chronic knee problem for over a year and a half now. Their knee's been bothering them and they can't straighten their leg all the way, but you're able to passively get them to full extension, but when you let go, their leg drops to around 40 degrees and they can't hold it up. And you get an MRI, it's like we mentioned a little bit earlier, and you note that they just have this big defect where their quadriceps tendon should be. So they have these chronic ruptures. What is your treatment algorithm in that case? And again, this is a patient that has a total joint in there as well.
That's interesting, because something you'll notice in your own when you go into practice is your algorithm might change with time. I have to admit, I was mostly an allograft reconstruction person first, because that's what I had learned. Mostly in the cases of a patient, let's say, really had no patella left. If they only have a patella, if you can get an allograft, you can put the bone in, trough it, and bring it up, and you can create a patella. Because the patella is a sesamoid bone, it does give you some power through your extensor mechanism. That's why we don't do patellectomies anymore if we can help it. But most of the times the patella is still there. And the patella is still there, I have to say, from a ease of use and a cost perspective, synthetic graft is actually easier to work with. So I'm a personal believer now in synthetic graft. especially over the context of a total knee. The hard part is to use synthetic graft. You have to make sure that that graft is not touching the surface of the implant in any way, shape, or form, because it's pretty abrasive. So you have to make sure that there's some sort of soft tissue covering over it, and then it can help scar the extensor mechanism down, or the quad tendon down in this case, but you don't want it exposed.
And so for your synthetic graft, this, again, this is just a synthetic graft that is supposed to be a substitute for a natural quadriceps tendon, which is being chronically ruptured, maybe atrophied. And so you go and you attach it proximally to whatever end of a tendon that you can find. And distally, just like you said, I guess you probably attach it more anteriorly than posteriorly, because you don't want it to touch the implant. Is there a specific a way that you tighten these? Do you have them in full extension when you do these synthetic grafts, or do you tighten them in 30 degrees of flexion, or I guess kind of what's your technique?
So I like to fix distally first, and then I call it water skiing. So to the med students on the podcast right now, you get to pull on the tendon as hard as you can with the graft. Or if you're the junior resident in the room, you get to pull as hard as you can, and then everyone sews like crazy around it. So the idea is I do an extension personally and put lots of tension on it, because all these do is they basically scar down and they can only become lax over time. So the tightest you'll get it ideally is at the time of surgery. So I do an extension and yank on it, suture it all down, and leave them locked in extension for at least 6 weeks, again with the bloodstone knee brace if they can tolerate it, or a cast.
Okay. And can you explain what a quadriceps turn down is? I know I've seen that as a possible choice, or possible treatment choice for these chronic, quad tendon ruptures.
Yeah, a quadricep turn down. I personally never performed one of these myself. But what
Okay.
you do is some of the quad tendon is always still there, right? There's something available in here. So because of that, you can actually cut part of the tendon and actually bring it down and have it create the other part of the tendon. So you use what's naturally there. The benefit, as we know, if there's a joint in there, you have an increased risk of infection. So you stick something foreign like synthetic graft, or you even stick an allograft in there, you increase your risk of infection. For quad tendon, you're taking the patient's own quadriceps tendon and bringing it down and overlapping it and creating a quad tendon. It'll be thinner than their tendon, obviously, because you're taking some of their tissue, but it'll be their own natural tissue, which is nice.
Okay. Awesome. Great. And so I think that was great for quad tendon rupture. And then last thing that we wanted to cover as far as the spectrum of our extensor mechanism is our kind of patellar tendon ruptures, the dreaded thing that you do not want to have happen to you at all. You don't want to cut the patella tendon, is what all of our joint replacement docs say during total joint arthroplasty. So say we have this unfortunate patient that has a total knee patella tendon rupture. Well, actually, what are some ways to prevent number one, a patellar tendon rupture or a laceration when when we're looking kind of through a total joint arthroplasty lens?
So first is listen to the harassment of the attending. They're harassing you for a reason, because they know once the quad patella tendon goes, you are in a lot of trouble. So the first thing is when you're doing dissections, you want to make sure that you know where the tibial tubercle is, and go just medial to that if you're doing a medial parapatellar approach. So you don't want to go into the quad tendon, the patella tendon in any way, shape, or form is the first thing. Two, everting the patella, that's a whole question in and of itself. They show there's no difference with regards to avascular necrosis of the patella. If you evert the patella, you probably put more tension on the patella tendon than if you don't. One thing to watch out for is looking for scar tissue in that area. There's always a little bit of band of tissue right by the tibial plateau headed up towards the patella, but it's not the tendon itself. You can release that with a knife, and I like to do it sharply dissection. And then when you do the, a removal of the fat pad, I don't like to skeletonize the fat pad. I like to leave some of the fat on there. Part of it's for vascularity and neurovascular, nerve structures being left behind, but it's also a good protection of the patella tendon. Like, reminder, there's a patella tendon here. If you do see the patella tendon peeling up, I always say that total joints are team sports. So if you see something bad, speak up. If you do start seeing it peel up, take a pin, and ideally a headed pin, and stick it in there at an angle so you don't get into the way of the tibial keel, to hold it down and keep it there until the end of the case, and then you take it out.
Right. Okay. And are there any patients that you may encounter that you're like, well, maybe, if I'm doing this case, maybe I should, be concerned that they may be at a higher risk for having a patella tendon rupture or some stiffness or just something that may happen with the patella tendon. Like I should just be very careful. Obviously, you should be very careful with every case, but are there any of those that you're like, I should pretty be very, very careful about these patients?
Right answer, always be careful with it. But anyone who has arthrofibrosis or stiffness, either it's because they've undergone multiple surgeries, because they're just stiff to begin with, it's a revision case, or a primary case, doesn't make a difference. If they're stiff, there's a really good chance that you're going to peel off the patella tendon when you're trying to flex up the knee, let alone exposure to everything else. But anytime you're flexing it up there, be careful of that. So know in advance that in these type of patients, you might have to do just something different for exposure than your traditional medial parapatellar approach.
And what would some of those, and we don't have to go all the way into detail, but what would some of those things be, just so people have a bit of ammo in their arsenal when they're maybe possibly getting pimped during their next total knee arthroplasty and they're having some difficulty everting the patella and don't want to lead to any type of patella tendon rupture?
It's a good pimp question, let me tell you. So um, my go-to is a quad snip. So you go up and then you snip it at like about a 45-degree angle upwards through the quadriceps tendon, which, scares all of us because we're trying to avoid the quadriceps tendon. But if you do that and you snip that and you close that at the end, most studies will show that you don't have to change rehabilitation. You don't need to change weight bearing status. You don't have to restrict range of motion because patients will restrict it themselves. So I have a low threshold in revision cases. I'm really struggling to just take the scissors or the scalpel and just do a quad snip. You can do a quad turn down where you kind of go up and then you turn an angle and you bring the whole quad down where you can almost flip it downwards. I feel like it can devascularize the patella more. So I try to avoid that, but it does give you even more exposure. I'm not a big fan of the tibial tubercle osteotomy because then you need the bone to heal around that. But that used to be the mainstay for a lot of people and still is for some people when they go down to the tibial tubercle. So instead of coming from the top and bringing it down from the quadriceps, they go from the bottom to the tibial tubercle, take a trough out of the tibia tubercle and actually lift the entire extensor mechanism, patella tendon, tibial tubercle, patella, and quadriceps all the way up in the air. So it's almost like a troch flip, we say. You just cut it open and then you expose the whole joint.
I wonder if that would be a patient who you may consider it in patients that, like, before they had their knee arthroplasty, had patella maltracking beforehand. Like I just wonder if that'd be like, oh well, maybe if we did did an osteotomy, that we can medialize it a little bit because that'll help with our total joint tracking, and we know that they already had pre-op pre-op lateral knee instability, and we're having trouble everting the patella. It's just a thought. I don't know.
Said like a true sports surgeon. That's a nice little focus in osteotomy while you're at it, which is a brilliant move. To your point, that's actually a very good possibility. Some people have combined that together, especially if they do have really bad patellofemoral disease. It is a possibility. The hard part is then you're doing two things at once,
Right.
and may not heal either well. But I will say the one thing that does favor tibial tubercle osteotomies is that it's bone to bone healing, which we know is better than soft tissue to soft tissue healing. So there are times that it's warranted, I would say, but I don't personally love it.
Okay. And what are some of the ways that we can treat these patella tendon ruptures?
So patella tendon ruptures are never fun things. It really depends on chronicity, I would say. So if it's acute, then you can actually try to, tack it down with suture anchors, and then take the same thing. I'm the Krakow stitch believer, maybe because Krakow did a bunch of joints, but bring it up the patella tendon, bring it down, and then suture anchor it down. So that helps. Some people like drill holes and putting screws across it. It's more robust, but I don't necessarily know if that's going to actually make a huge difference. Suture anchors are really good nowadays. Now, if the patient has really bad bone, they're really osteoporotic, which can be the case in a lot of our patient population, then if you put the screws, you can actually pull down the tendon and then wrap them around the screws and bring them down. So that seems to be helpful when it comes to acute ones. A lot of times, and then one of the areas I would also say too is that, if it happens during surgery, right, you can tack it down. I've had them come up before during surgery, which is a never fun feeling. But then you ask them for whatever, suture anchor that they have, and they go, which one do you want? And they give you 5 different options. And you go, I haven't done sports in so long that you just give me the one that works. And then so I put it down there too. And that's for my acute ones, intraoperatively. If it happens to rupture in the mid substance of it, that's not as common, I would say, but it can. It normally avulses, I would say. You can just do end to end and suture it down that way too. The chronic ones are absolutely the hardest ones. It really depends on how you want to reconstruct it. One of my partners actually just did one yesterday where they actually harvested the hamstring. So think of an ACL harvest, and then tunneled it from the pes upwards toward the patella tendon, wrapped it around the patella in 2 different directions, and brought it back down and sutured it all down. So that was a new one. Yeah, I've never seen it before, never done it before, but he was describing it to me, and I was like, that's pretty cool. So you can do that. The more traditional ways are to use allograft as opposed to autograft, and those allografts can be like Achilles tendon. You can use that one. You can use patella tendon allograft. That's harder to find, but you can use that. You can use a bone block. In this case, and you can take the Achilles tendon and the bone block from the calcaneus and trough it in there, and then lay it over and make up for the patella tendon that way. So you can do it with a complete extensor mechanism reconstruction with allograft. Harder to do though.
Yeah, and since we want to talk, spend some time on, allograft or extensor reconstruction. What does this surgery consist of? I know we just said that is one of our options for our patients that have these chronic, patellar tendon ruptures, where you get the X-ray and you see the patella's way up by the mid femur, or it's pretty much not where it should be. It's a lot higher than where it should. And you're considering that. What is an allograft extensor reconstruction? Kind of what is some of the procedure? And then I know we have a couple slides or some things that we definitely want to touch base on here in a bit.
So it really depends, I think, on whether or not you have to revise the components or not. So in the cases where you don't have to revise the components, say the rotation is good, they're all well fixed, there's no problems with it. What you can do if you're doing an allograft is you can trough the bone in the tibia, lay your allograft bone block in there, either with the extensor allograft or with the Achilles tendon one, and then you want to feed it up through what already exists there. So in this case, for it, what you want to do is you want to make sure that you oversew and you bring it over to existing soft tissue. The mesh is something a little bit different. When you have to do it is where you have to sandwich it so you protect it from the soft tissue. That's a whole different area there. But for the allograft specifically, you want to make sure that you want to do enough host bone so you don't break a bone bridge. I always say 15 millimeters is good, because you have that bone bridge, then you can actually bring your allograft over it and then sew it down to it. Some people like to put wires around the tibia when they're trying to fix down that bone block. That scares me a lot. I don't like putting things posteriorly in the tibia if I can help it. So I'm a bigger fan of taking screws and driving it through the bone block and then holding it trauma style.
Okay. And so do you have any tips as far as noting whether or not your component is going to be, stable or not preoperatively, just looking at the x-rays, or anything that you look for, you're like, oh, I mean, that obviously is going to be loose, or I think that'll be loose. Like, what are some ways that, looking through your eyes, that you look and evaluate those x-rays?
That's how, when most of these patients are not coming in acutely, they're not coming to the emergency room, they're normally coming to your clinic. So because of that, you have a little more time to work things up. So in all these cases, I always work up an infection first. I get an ESR and CRP on patient, I aspirate them and see what it looks like. If I want to see what the soft tissue is like, which most of the times you don't have to do, because you can see from the x-ray if you say the femur's the patella is flapping in the breeze in the femur. In those cases, you just need an x-ray. But this is where a bone scan can actually be helpful. I wait to do a bone scan at least a year after surgery. And if the bone scan lights up, it can be inflammation or infection. And it can show loosening in these cases. And they're pretty sensitive. If it lights up, it's pretty sensitive. It is pretty it's pretty specific. It's just too sensitive and not as specific, right? So if it lights up, doesn't necessarily mean that it's loose. But if it doesn't light up, there's a really good chance that it's not loose. And I always check them intraoperatively as well. But it's not loose, then you don't have to mess with it. A lot of these times, though, I feel like patients are undergoing revision. For example, for a patient who has a two-stage exchange, they've already gone the first stage of surgery. And for the second stage, they need to get a reconstruction because their extensor mechanism out and you have to reimplant them. So you know you're going to have to put the implants in.
And is the extensor reconstruction, is it just the blown block with some, so an allograft tendon with a patella, or with another piece of bone in the middle? Some place I've read is they remove the patella from the extensor expansion. I guess what all they're referring to when they talk about showing the patella from the extensor expansion.
So you got a lot of options. The two options that mostly are used though are the Achilles tendon allograft and the complete extensor mechanism allograft. And the complete extensor mechanism allograft has the tibial tubercle, the patella tendon, the patella, and the quad tendon. It's got the whole
Okay,
9 yards and harvest.
everything.
Right. So in those cases, like a patient who has either a patellectomy, which used to be the mainstay of treatment, way back in the day. And I've seen a few patients come in my clinic with a all out patellectomy and lived with this for, 30 years, which is impressive.
Yeah.
Those are cases you probably want to reconstruct because you want the patella. And most of the times the patella is either still there, and if it's really scant or had a previous fracture and it's completely kibble and bits, then a complete extensor mechanism reconstruction would be good in that case with regards to an allograft of the whole thing. But most of the time, if the patella is there, you can get away with just an Achilles tendon allograft.
Okay, so our indications to do a complete allograft extensor reconstruction would be one, if there's just not really much, not much, patellar bone there. These are chronic disruptions where the patella is really high and there's not much bone to really hold anything. That would be kind of one of our indications to undergo this. And then another would be if they had some prior patellectomy, in the past, and now they have this, chronic patella tendon rupture. That is another indication to proceed with extensor reconstruction. Are there any other indications to have a complete allograft extensor reconstruction?
Mostly if you need the patella, I would say. So those are my two go-tos.
Okay. And so when we're looking at extensor, mechanism reconstruction, I know we have a couple principles for success, at least 8, just as a wild guess. But
You are
what are
so
some of
good.
what are some of our what are some of the things we need to be on the lookout for? How do we get set up for a successful mechanism reconstruction?
So number one is to not even do it. If you can help it, if the patient doesn't need it, then that's great because you can only you won't make them worse if they already had the problem, but they never had an extensive problem in the first place. You can only make it worse. So avoid it if all possible. Patients who have a high likelihood of extensor mechanism problems. One, be careful when you're dissecting them, when you're performing the primary. Two, maybe consider earlier mobilization, which is hard because you have to balance that with stiffness that happens in the postoperative period. And be really, really careful to not cause problems in these patients during surgery. That's what the ones we walked like a hawk. So if you can prevent it in the first place, that's number one. For the second one, you want to make sure that you have the allograft and you actually like it. So the idea is when you get the allograft itself, they normally don't just cut out the tibial bone block because they want you to be able to take it out. So make sure that you have enough bone in your bone block and enough tendon to sew into. Because if either of these are deficient, then you really want to make sure that you have a good one. And normally what I use as a rule of thumb is 5 centimeters for the tibia, 5 centimeters of quadricep tendon. It's interesting because you can order these in different ways. The tibia is normally a standard one, but for the tendon, they sometimes say, do you want 5? Do you want 7? Do you want 9 or 11? And we always think bigger is better in ortho, but it's not always the case. So you need at least 5 though for your tibia, for your quadriceps tendon.
Yeah, that's exactly what I was just about to ask. But so does patient anatomy, does anything ever change with patient anatomy versus how much quadriceps tendon that you want? Like if this is a very, very, super chronic uh patient where the mechanism has been out and the patella is way retracted, are you considering, oh, well, maybe we need more, or do you still stick with that 5 almost every time?
5 is minimum, I would say. I would try to go longer in all honesty because it's easier to cut down. Now the price does go up when you get longer and longer ones. Normally, another area I look at too is a patient's height. So if a patient's really tall, there's likely to need potentially more quadriceps tendon in that region. So I don't want to make them Baja, right? So, and I also want to make the
Right.
patella tendon long enough too. So patient height will make me go for a longer one.
Okay. And
All
what
right.
would be the third key for success?
So as an orthoplasty surgeon, I've got to look at the metal and the plastic. I got to make sure that they look right. If they don't look right, then I will definitely want to revise them. You asked me earlier what I look at. Bone scan is one of them, to see if an implant's loose, but it's not very good at, making sure that it's not loose. So I still inspect during surgery itself. 2, if there's instability. If there's instability in the joint, so the patient needs to go to like a higher constraint implant. They have a CR or even PS1. Maybe they need a total stabilized one or a semi-constrained or even a hinge in some of these cases. And finally, if the components were actually put in incorrectly in the first place, you can get a CT scan. And looking at the axial views, you can actually follow the rotation through and see if it needs to be changed. Because if it's internally rotating, then we know the patella could be tracking incorrectly, and that could lead to extensor mechanism problems.
Right. And we mentioned a little bit earlier when we were talking about getting these bone scans, just really quickly to touch on that and kind of how it works. Because I know we have residents that listen to this as well. And so maybe trying to learn, future joints fellows in the making. But when we're looking at a bone scan, the bone scan works because it is pretty much a scan that shows you anywhere where there's increased activity in the osteoblast or osteoclast. So if you're concerned for an infection, typically there's an uptake in that area because those bone cells are more active than the other areas. But if you have a fracture or anything going on, if you have a fracture and there's healing bone, you also have uptake in that area. Is that pretty much correct for the most part?
It's a good way to put it. It's a good description.
Okay, good. Perfect. Just for those that are listening, we hope you understand what a bone scan is and how it could kind of help when you're evaluating these total joints patients. So continuing on, what are some of the other things that we should that we should know about when we're going to go and do our reconstructions?
So minimally invasive surgery is MIS, but MIS can also stand for maximally invasive surgery. That is what you
Ah,
want to do. You want to
I'll
make
use
sure you
that.
have plenty of room. Exactly. Well, sports, maybe not so much, but the rest of it, maximum. So, one of the things I like to do in all honesty is to prep out the entire leg and have a lot of space and then put on a tourniquet sterilely if I need to. So that's one thing that I think is really helpful is make sure exposure is enough and make the incision as long as we need to. Follow the old incision. And I always tell a patient, I'm going to cut it above and below. So your incision will be even longer, even if it's a long incision to begin with. And make sure that you expose everything so you can get through the scar tissue. It's kind of nice if you're not keeping the patella, you can actually just peel straight down and cut it and open it up. So that makes it a really nice exposure in all honesty, much easier than total knee.
Right. Yeah. Okay. Much bigger. And for those that are watching on the YouTube channel, for those that are listening, we have a picture up here. But for those that are actually watching on the YouTube channel, can you kind of just describe what we're looking at here on this picture?
Yeah, so we're looking at, so on the left side is proximal and the right side is distal. And you can see the patella in the center there. And so what the idea is you can cut straight through the quadriceps tendon up above the patella, actually skeletonize the patella itself, and then cut down the patella tendon because we're going to thread everything in here or remove it and reconstruct it. So you're going to want to thread it through. So you actually just skeletonize the patella as opposed to doing a medial parapatellar approach.
Ah, okay. Perfect. Makes sense. And this right here is just that patella being skeletonized.
It's a
Correct.
fun feeling. Normally you want to avoid that patella like the plague, and all of a sudden now you get to cut down straight into it. It's a great junior resident case, actually.
Huh. I have never done one, at least not yet. I will be on joints again soon. So, well, I hope I am not hoping that a patient has one of these, but if this case comes, I would be more than happy to be in this case.
You are prepared. I like it.
Exactly, prepared. That's more kind of what we're going for. And these are kind of exposures. This is showing us our total joint. And what is this showing us here? Is it showing us that everything is being taken out?
So two things. One is that there's flaps on the side, right? So you want to have these nice, thick, robust flaps because these are what you're going to sew down and recreate over it. And then two, you can actually just see the implant itself and just make sure that it looks good. If you're not going to remove it, make sure you have enough tibia exposure. So you see normally when we do our tibia exposure for a primary, we only go to the tibial tubercle. This is way past the tubercle, right? One, because you want to preserve the extensor mechanism normally. You want to have this distance because when you trough, again, you need to have a good at least 15 millimeters or 1.5 centimeters below the joint line to create a trough. And if you want a 5 centimeter trough, you need to be able to fit that in.
Awesome. Great. And four, what is our next key?
So we want to make sure that the allograft is prepared correctly. This is one of those things where you think of sports and preparing like a ACL graft, someone back table does it, or someone else does. This is something you want to be actively involved in if this is your case, because if you mess this up, these allografts aren't sitting around. You can't just go in the back and get another one of these, right? So treat this as you would an autograft. This is one of a kind. Make sure it's right, and you want to prepare it correctly.
Okay. And when you say preparing, just like you said, making your cuts in the tibia, making sure you have enough bone stock, and then just, I guess, just anything else that goes into preparing these.
Yeah, so it depends on how you want to prepare it. So if you go distal here, some people just want to cut a rectangular wedge and wedge it into a rectangular shape. Some people say it's actually good to kind of bevel it. So if you bevel it at an angle, you kind of fit it and lock it in, almost like a puzzle piece. It just gives a little bit more fixation to keep it from flipping upwards. It can still flip upwards and migrate upwards even with fixation, but you want to make sure it's a thick enough block, because if you make it too thin, the bone won't hold it. The screws won't hold through the bone, or the wire won't hold through it if that's the case. Otherwise, you can trough it around it. So this is the trough that you want to put in here. You can see the dimensions here of like a distance from the joint line surface, the actual length of this. And this is a good size bone chunk. We're talking 6 to 8 centimeters. You said a minimum of 5, but 6 to 8 is ideal. And again, you want to include the top of the patella, the top of the tibia, where the top of the patella tendon is attached to bone, and then enough distally to have fixation into.
And so any tips with it as far as preparing the host tibia? I know we just talked about, having our distance from the plateau and going at the top of the tendon, but anything else as far as preparation with the tibia?
Yeah, you want to make sure that it kind of fits like a glove. You want to make sure that what you trough and what you prepare in the tibia is similar to what you get in the host bone as well, too.
Yep. And this is what we're doing here. We're kind of making our cut, getting our wedge out. And this is that rectangular shape that you were talking about in our tibia. And then, so what about our fixation of our allograft and, kind of that host junction?
So that's a dealer's choice sort of thing. Some people prefer wire, some people prefer screws. It depends on what you feel like. Again, the hard part about the screws is that you have to have a thick enough and robust enough bone to get it across and drive into it. The other thing you have to watch out too is for the keel or the implant keel. If you drive screws across it, you almost have to drive it at 45-degree angles, because you want to make sure that you avoid that keel. So some people do prefer wires, and they kind of put it around it and then turn it and fix it down. But that's a dealer's choice. You can do either one as long as you have good fixation.
And can you just briefly explain what the keel of an implant is for those that may not have done joints yet?
Well, then you're missing out. So you have something fun to look forward to.
Very true.
So in the femoral component, depending on what type of component it is, there's either 2 little pegs in it or a box holding it in. For the tibia, though, it takes a lot of brunt of force, as you can imagine. So if you just put a tibia and just cemented it on top, it could rotate and move. So what we do is we put something down inside the tibia that goes into the bone, and it fixes this, we call it the keel, where it holds rotation so it doesn't move.
Love it. Love it. All right. And this is kind of us, or how you get your fixation. And so what about your proximal fixation? What, I know we talked a little bit about it earlier when we were talking about our quadriceps tendon repair, but what about for these reconstructions? What does that have to, what tips do you have as far as proximal fixation?
I'm a big fan of pulling, pulling, pulling. So that whole water skiing move is real. You want to do it under tension, extension of the leg, and really, really pull hard on it. Krakow sutures are good because it interlocks and laces down and pulls down, and then put distal traction on the native quad. So you pull in opposite directions. You're pulling up proximally and you're pulling down distally. So when you have this creation, then you sew into it, then you get the maximum tension, because again, this graft will only get loose over time. So this is the best it's going to be. So try to make it the best that you can. A lot of times people afterwards say, okay, here we go. I just did the repair. Let's flex up and see how it works. Don't test it. Testing it only loosens it and only messes it up. You want it to turn to one big scar ball, and then they can test it.
And so, what are our other two keys for success? You know, we went through about 6 of them right now, but do we have what are our last 2 keys that we should know?
So number one, so one of two. Number 7, I guess, would be the key things would be cover the allograft with host tissue, right? Because again, you want it to scar down. Allograft is foreign tissue. It doesn't scar down. There's no biologic tissue to it, but it can scar to biologic tissue. So you'll make sure it's with the host tissue, and make sure that you have a protocol. There are protocols that are available in papers. You know, personally, I keep it for almost 3 months. I actually try to keep it for 3 months straight. And the reason is because A, I don't trust my patients, and B, this is their one shot. So make sure that post-operative PT is correct, but people equate keeping their leg in extension with not exercising. And that's far from the truth, because their quads will truly atrophy. So straight leg raises their friends, they can walk with their legs in extension, all those things. So you want to make sure that physical therapy understands, and that physical therapy isn't afraid that they have extensor mechanism reconstruction, and just avoid any sort of exercise.
Okay. And the last thing I wanted to touch on before we wrap up here in a second is the use of mesh. What role does mesh play in, in our allograft reconstructions, and do you use mesh with every reconstruction you use, or what is his role, and why do you use, or whatever thoughts or opinions you have on it?
So mesh is a game changer in my book. The guys at Mayo really made this a reality, and Arlen Hansen is really to be credited for this. And it's awesome. One, it's available because people in vascular use it all the time, or in the general surgery world use it. So you don't have to get something special like an allograft. 2, again, it's just you're using stuff that's available. You suture up and down. The key factor I would say with the mesh is that they're bi-directional. If you pull it in one direction, it stretches more. If you pull in the other direction, it doesn't stretch as much. You want the side that doesn't stretch too much, because you don't want your graft to stretch out. That's a problem. So what I do is all my cases now that I use extensor mechanisms for are with mesh. And the reason it's really good, I think, is because you can use it in 2 ways. You can use it with existing implants. And what you do is you create a trough with the burr, and you feed it into there with cement and then suture it over. Or when I'm redoing a reconstruction, I can tuck it under an implant and then use that cement as my fixation, do the implant on top of it, bring it over, and then suture it around. So it creates a nice scar ball. I feel like the ones that I've done have had no extensor lag, which has been awesome. The reflection goes to about 90, which is, not ideal, but not terrible. It's better than nothing. So I will take it and run with it.
That's awesome. Well, Dr. Chen, I think this has been a great talk on, number one, going over, kind of the different ways, the different parts for the extensor mechanism, and kind of the risk factors for total joints. We talked about the patellar tendon. We talked about the patellar tendon ruptures and ways to avoid that, especially number one with our exposures. We talk about the VY, no, not the VY, the quadriceps snip. We mentioned the turn down. We mentioned making sure that you are medial to your tibial tubercle. We talked about the patella fractures, and how we, definitely don't want to make sure that our cuts are not too thin. I think we mentioned 12 millimeters, at least 12 millimeters that we wanted for our patella bone stock to be in place. And we talked about, kind of the quadriceps, things that you be on the lookout for on the x-rays. And I overall enjoyed this conversation. Dr. Chen, is there anything else that you would want people to know about, this extensor mechanism reconstructions before we wrap up here?
You nailed it. It was all really good. It's a good recap there, and it's useful in trauma and in joints as well too. So it's good all around knowledge to have. So hopefully, you don't have to encounter too many of them, but when you do, you feel ready.
Right. And Dr. Chen, we always, give our guests or our speakers at the end of our episode any way for our guests to reach you or build your brand. If you have social media that you would like people to follow you on, or somewhere if you want people to email you or anything, if you have anything that you would like to share with the people, go for it. If not, that is completely fine. Totally up to you.
Two ways. One is something called Twitter, which I didn't know well before. You guys know it well, all too well, at Dr. Antonia Chen, or by email. My email is afchen@bwh.harvard.edu. So any way you want to reach out to me, please feel free.
Well, again, Dr. Chen, this has been an excellent episode. Really appreciate you for taking the time out and coming on the podcast. For the listeners, thank you all for listening to yet another episode with Nailed It Ortho Podcast. Please and go and leave us a review in iTunes and let us know how much you liked this episode and how much you learned. And again, hit that subscribe button, and we will see you all next week.